exercise or with LVH should have intervention. So our gentleman had a trileaflet aortic valve, though interestingly, when we did a bit of digging, his father had actually had a bicuspid aortic valve, which was the reason for his heart surgery in his 40s. He was suitable for stent intervention, so he had a covered stent inserted, and these are just stills from his cath lab procedure, pre-stent and after stent implantation. And we saw him back in clinic. His blood pressure was 139 on 78. In his right arm, and he'll be followed up every 2 to 3 years if he's got good blood pressure control with exercise testing and repeat imaging. So the stent can fracture, he can get recoarctation despite stenting, and because he's a late repair, he's more likely to still have blood pressure issues, so he'll probably remain on an antihypertensive agent for the rest of his life. Fourth case. It's a 24-year-old female who was brought in by ambulance with a syncopal event at work. She had a history of tetralogy of Fallot repair as a child. She'd been lost to follow-up, and I guess there was a few different versions of this, so her impression was that she was repaired and didn't need to see anyone ever again. She was working in an optician, so was on her feet for long hours during the day, not on any medications. When she came in, her blood pressure was fairly normal for a young female. Heart rate was normal, SATs normal. She had a sternotomy scar as expected. She had a loud diastolic murmur, loudest at her left upper sternal border. Lungs were clear and no peripheral edema. So tetralogy of Fallot is the commonest form of cyanotic heart condition. It's accounted for 3.5% of all congenital heart disease and 1 in 3,500 live births. It's comprised of a VSD, aorta that overrides that VSD, right outflow tract obstruction, which can either be at the level of the pulmonary valve or anywhere along the right outflow tract, and resulting right ventricular hypertrophy. 3% of these cases are associated with anomalous coronary arteries, and 15% of them are associated with DeGeorge syndrome, which is an autosomal dominant syndrome. So her ECG showed what's fairly typical of a Fallot repair patient. So she had a right bundle branch block pattern. She was in sinus rhythm, and they didn't capture any arrhythmias on her ECG. And her echo was also fairly typical of what we would see in people with repaired Fallot. So her right ventricle, so this is her left ventricle, this is her right ventricle, is hugely dilated and also hypertrophied. And that's the same thing really, just in a short axis view. And this is her right outflow tract, so you should be seeing pulmonary valve tissue up here, and you can see something rudimentary, but she's no functioning pulmonary valve. And she's free pulmonary regurgitation, which is the murmur that we were hearing. So traditionally, Fallot repairs are done by closing the VSD and then relieving the outflow tract obstruction, and that's usually by resecting the infundibulum of the right ventricular outflow tract along with the pulmonary valve, so performing a valvotomy, and that's why these patients are all left with pulmonary regurgitation. Many patients also require a transannular patch, which is where they kind of have to widen up this outflow tract area. And that's just important to know about because it determines what re-interventions they may be suitable for later in life. Currently, we're trying to move towards valve-sparing surgery as much as possible, so it means that they're left with some kind of functioning valve, and plus they'll be amenable to percutaneous redo procedures later in life, which those who've had a transannular patch are not amenable to. So really the late outcomes for tetralogy of Fallot patients is all determined by the function of their right ventricle, and we know that those who have higher burdens of arrhythmia, decreased exercise performance and sudden death, or all those who have volume loaded right ventricles. And it's the pulmonary regurgitation that determines how the state of the right ventricle is. So increased pulmonary regurgitation means there's increased loading conditions on the right ventricle, which ultimately leads to decreased contractile function and to diastolic dysfunction. The Brampton group looked at a large cohort of nearly 800 patients with tetralogy of Fallot repair, and of all the patients who had sudden unexpected deaths, 100% of them had at least moderate PR at their last follow-up. So people who have severe pulmonary regurgitation should have pulmonary valve replacement those who are symptomatic should have pulmonary valve replacement. Those who are asymptomatic should be considered for pulmonary valve replacement if they have a objectively identified decreasing exercise capacity, progressive ORV dilatation and systolic dysfunction, or if they have sustained arrhythmias. And that we know that implanting or replacing the pulmonary valve improves the right ventricular volumes and right ventricular ejection fraction. It also improves the left ventricular ejection fraction. It decreases their QRS, which in turn decreases their arrhythmia burden, and their symptoms improve. The timing of the pulmonary valve replacement is the area that's still controversial. Because these are tissue valves, we only get about 10 years out of them. So if we intervene too early, then we're in this cycle of redo interventions, which we also want to avoid. And valves in the pulmonary position also have a higher incidence of endocarditis because it's a low flow system. So Our Lady on telemetry was identified to have short runs of non-sustained VT, so was commenced on a beta blocker. She had a surgical pulmonary valve replacement done. She had a transannular patch repair as a child, so wasn't suitable for percutaneous pulmonary valve. We implanted a loop recorder at the time of surgery, but thankfully she hasn't had any recurrent VT since her pulmonary valve was replaced. She reports improved exercise tolerance, and we'll be following her up for life every 1 to 2 years. She also needs to receive antibiotic prophylaxis for any dental procedures in the future. I think I'll skip case 5 because we probably don't have time. And just in summary, these are rare conditions, but they are increasing in prevalence. So you will be seeing more and more of them in your clinics. All women with known cardiac conditions should be receiving preconception counselling and cardiac monitoring during pregnancy and the postpartum period. And all adult congenital heart patients or aortopathy patients should be followed up in specialist units. And if in doubt, have a low threshold for referral on to a specialist centre. I'm very happy to take any questions.
Thank you very much, Carla. So the questions will be going to the webinar as well, so if people wouldn't mind just waiting for the microphone before asking the question. But just before we start, I might just ask a question or two. You said at the start that there's an increase in congenital heart disease. Is there a reason for that? Is it just that it's being diagnosed earlier, or is there a background to that?
Yeah, it's probably a combination of increased pickup. I guess the other reason, potentially increasing maternal age and increasing complexity of the health issues of people giving birth is playing a role. We don't really know, because obviously birth rates are decreasing, yet we're seeing an increase in the prevalence of congenital heart disease, both at paediatric and at adult level. So we're not 100% sure why that is.
Okay. Are there any questions? I might ask another question then. From a GP point of view, are there any kind of red flags that we should be looking out for if we're thinking maybe congenital heart disease?
I'd like to think that now most of these patients are going to be picked up in childhood, so they'll probably be hopefully coming to the GP clinic with a diagnosis known. And I think certainly one of the strategies within congenital heart over the past few years has been tightening up transition programs so that there's a direct path from the paediatric centre to the adult centre. From, I think, the commonest complications we see across the board, obviously each individual condition is slightly different, but is these patients developing rhythm abnormalities. So low threshold for performing an ECG if you have the facility on site, or sending them to an A&E for an ECG. We try and provide all of our patients with contact details for us, and with kind of the equivalent of what we, kind of a patient passport, so their diagnosis is outlined on that, so they can present that to the A&E, and they can contact us if needs be, because these are quite rare conditions. They just need a specialist opinion early rather than late.
Okay, super. I think we have a question here.
Carla, what's the prognosis post-surgery? So after valve replacement, what is their prognosis?
For
tricuspid valve replacement, if there is.
For pulmonary valve replacement, is
That's
it?
Right, yeah.
So with tissue pulmonary valves, they'll get about 10 years out of a tissue valve.
And would it need to be replaced again?
Yes. So that's why the timing is so controversial for tetralogy of Fallot patients. So if we intervene too early, we're in a cycle of having to do repeated interventions. hopefully with this new generation. So currently our adult population are predominantly those who've had transannular patches and valvotomies. So a small proportion of them are suitable for percutaneous valves. Hopefully with the newer generation of valve sparing surgery done on children, more and more of those will be suitable for percutaneous pulmonary valves, which at least means we're not having to do reduced sternotomies every time they need a pulmonary valve. So things will change as we get progress, but at the moment, most of the adult population, we're talking about reduced sternotomies for pulmonary valve intervention.
Thanks.
Sorry, yeah, thank you very much. That was very informative. I was wondering what materials are used in those devices other than the venous,
The ASD closure devices are usually nitinol mesh.
Mesh?
Nitinol mesh, yeah.
Thank you, Dr. Canna, for a great talk. I'd like to ask one question. As a GP, what are the red flags that we should look for in our pregnant patients going from, say, the 3 trimesters? Are there any particular cardiological red flags?
Yeah, so it can be tricky because obviously a lot of the symptoms that are cardiac symptoms are also common symptoms in pregnancy. So increasing breathlessness, increased palpitations, these are all normal things that women report during pregnancy. I think taking a full history and taking women seriously is really important. So people who are coming back complaining of these symptoms repeatedly need to be referred on, just having a low threshold for referring them on, and then also anyone who's already in a higher risk category, so over 35, diabetes, raised BMI, previous complications during pregnancy, and obviously if they have a known cardiac condition, I would hope that we're moving towards anybody who has a known cardiac condition already being plugged in to a cardiac maternity facility. But anybody else in those kind of higher risk categories, I'd have a low threshold for referring on for further investigations.
Okay, are there any more questions?
Role for anticoagulation in any of the valve repairs or cardiac repairs, and if so, for how long?
So it depends on the valve. So obviously with mechanical valves, we will anticoagulate. The tissue valves, we usually have them on an antiplatelet agent, and we try and leave them on for life. Our patients are a young cohort, so that can be challenging, but the tissue valves don't need anticoagulation.
So are there any more questions? No. Okay, thank you, Carla. Thanks very much.
I need a chair. I'm going to take this chair.
Okay, so our next speaker now is actually Professor James Paul O'Neill, who's a consultant in ENT and specialises in benign and malignant conditions of the head and neck, thyroid and parathyroid disease, and is going to give us a talk today on ENT head and neck examination and red flags for cancer. So thank you.
Great, thank you very much. Good morning, ladies and gentlemen. Thank you very much to Blackrock for the invitation to be here. So we'll start off. This is a patient who didn't like the look of the back of his throat, so he decided to take a selfie. So you can see here he's got a tumour which is coming off his tonsil. Decided to do nothing about it. Took a selfie a couple of months later. Did nothing about it. Took a selfie another couple of months. Did nothing about it. We're now up to 2015. Did nothing about it, except he now began to get some ear pain. And so with the referred pain, eventually, reluctantly, he went to his general practitioner. And why is this patient alive today? Because this is a HPV oropharyngeal cancer. Okay, so I'll talk a little bit more about that in the near future. But we're in a different era of disease, and we're in a different era of patient as well. So today we're going to talk about ENT examination, red flags for cancer, lymphadenopathy, and I'm going to talk briefly about 4 subsites in the head and neck. So first, the examination. So I'd just like to get a victim, if I may. Actually, I'll get one of you two ladies up here. So the one thing I just want to just talk about and just show is in particular cervical lymphadenopathy. This is one of the things in medical school. You'll see people kind of, so obviously I wash my hands, but you'll see people doing this. Oh yeah, that's grand. Fine, okay? So that's not how to examine for cervical lymphadenopathy. That's the way I did examine cervical lymphadenopathy. And in 2011, the chief of my service in New York said, "You're the new Irish guy. The patient in there, you examined their neck?" I said, "Yeah, N0, N0. So he went in and he found a node and said, "That's not acceptable." So the node was there. He said, "That could be positive. It's certainly palpable." And that's the big no-no in a cancer clinic, that someone comes in and walks out and you don't detect disease. So what we do is we do a good inspection all around the head and neck. We're looking for any changes in the skin, lumps, bumps, asymmetry, etc. And then in terms of examining the cervical lymphatics, I start in this area which is known as the level 1. And I walk along like an army of ants. Level 1B, which is the submandibular, excuse me, submandibular gland. At the angle of the jaw, I go up to the preauricular area. Just with my fingers just palpating, can I palpate anything? Around the top of the ear to the mastoid, so I can find the sternocleidomastoid. Look up now, please. And now I walk along the anterior border of the SCM, walking down. This is what we call levels 2, levels 3, levels 4, until I'm at the tracheoesophageal junction here. We call that level 6. Okay? Then I put the patient's head forward, and at the back, basically using 2 hands, I'll go up to the midline of, this is what we call the level 5 area, and then the more lateral areas of the level 5. Okay, so my thumbs, fingers, palpating for lymphadenopathy. Then go into the supraclavicular fossa. Okay, so I'm in the fossa, down to the floor, forward to the clavicle, and back. The bump in the road is the brachial plexus, and I'm pinching trapezius. Okay, so we'll do that quickly there, so look up there for me. So I start here in this level 1, walking along, angle of the jaw, up, around the ear, mastoid, staying anterior to the SCM, lateralizing as I walk down levels 2, 3, 4, level 6, head forward please, central areas of level 5, lateral areas of level 5, supraclavicular fossa, down to the floor, forward to the clavicle, and back. She has no palpable cervical lymphadenopathy. Okay, so that's just what I wanted to highlight, because the condition of the cervical lymphatics is the most important indicator or prognosticator in head and neck disease. If you have one node with squamous cell carcinoma in it, your survival drops by 50%. Okay, so lymphadenopathy is very, very important. Thanks very much. So let's move on. There's obviously lots of different types of head and neck disease. We have oropharyngeal disease, skull-based paranasal sinus disease. So you can see here this disease going through the skull into the frontal lobe. That lady is still alive. She's 34. We took the ipsilateral frontal lobe, which you can take without any cognitive change. This is a gentleman here with squamous cell carcinoma on the skin here, metastatic disease in the level 5, which is posterior to the sternocleidomastoid muscle. That's a salivary gland tumor. This is a floor of mouth tumor. This is laryngeal cancer, and this is thyroid cancer. So the main risk factors: smoking, no surprise here. Smoking and drinking, even worse. Sunlight, and of course the new player on the market, which is the HPV-driven disease. And we get this process of hyperplasia to dysplasia, which is where you get this altered maturation of the cell layers, and then finally into an invasive process. Remember, what's cancer? It's invasion. Okay, it's the only thing that can invade is cancer, and cancer is an invasive process. So these are the red flags: a lump or a swelling in the neck, and a persistent lump or swelling in the neck. A sore throat that won't heal or that bleeds easily. If anyone wants copies of these slides, by the way, just send me an email, I'll send you the whole lot. A red or white patch. So a red patch in the mouth is called erythroplakia, or a white patch leukoplakia. I'll show you a slide of that in a minute. Frequent nosebleeds, ongoing nasal congestion, chronic sinus infections that don't respond to treatment. Anything that's chronic, just be careful. Okay, because you could be dealing with something that's not just persistent infection, which is what we would understandably think it is. It's just sinusitis. A persistent sore throat, persistent hoarseness or a change in voice, pain in the neck, throat or ears, in particular a unilateral pain. Blood in the sputum, difficulty chewing, swallowing or moving the jaws or tongue, numbness, loosening of teeth or dentures, and a discoloration of a mole, or itchiness in the skin, or anything that would indicate a sign of a skin cancer. So these are the main reasons why we have cervical lymphadenopathy: malignant reasons, infective reasons, inflammatory, and congenital. So here's a patient with a rip-roaring tonsillitis, okay, and they have a level 2 cervical lymph node, and this went down in the course of 3 weeks. This is another patient here that you can see they have, this is level 1B, so this was actually sialadenitis, inflammation of the submandibular gland, but she also had a matted fixed number of lymph nodes in the level 2, 3 and extending into level 4 area, and this was non-Hodgkin's lymphoma. This is a patient here, an adult, who presented with this midline swelling, and this is a thyroglossal duct cyst. Okay, so your thyroid develops, anything really important develops really quickly in utero. Okay, so your thyroid develops about week 3 and descends week 7 to 10. And that pathway of descent is called the thyroglossal duct tract. Okay, and this is a cyst within it. And the operation we do there is called a cyst trunk. We remove the cyst and the central portion of the hyoid to prevent it coming back. They can very rarely have cancer within them. So the neck is really important. This is basically an outline of what we've already looked at. So what do we look for in the history in lymphadenopathy? We look for the duration. Beyond 3 weeks, really, in an adult, we begin to get worried. Okay, we need to investigate that. Localized lymphadenopathy of brief duration often accompanies some infections. We're all aware of that. What about the consistency of the nodes? So it shouldn't really be used to distinguish between benign and malignant. However, rock-hard nodes are commonly seen as malignancies, and tender ones will often indicate inflammation or infection. So I'd be happier if I put my hand on someone's neck and they go, well, it's a bit sore. That's better than having a rock-hard node where they're saying, you know, I just noticed it shaving this morning. Mobility, fixed or matted, suggests metastatic disease, and freely movable may occur infections, collagen vascular disease, lymphoma. So in terms of investigation that we would perform is we'd look at an FBC, throat cultures, a monospot, LDH, which is a marker for lymphoma, thyroid function tests, a MAN2 test for TB, HIV, hepatitis. I would do a full examination, endoscopic assessment of the pharyngolarynx. That's really handy where you have these small scopes that we just pop in through the nose, have a look at the laryngopharynx, and then obviously radiological imaging. We get a fine needle aspirate or a core biopsy, and then discuss these at a multidisciplinary setting. Okay, so to move on to 4 areas of the head and neck, here's the oral cavity. That's leukoplakia. That in a smoker, be very careful because it can be dysplastic. And severe dysplasia, we rate dysplasia called the Ljubljana classification, mild, moderate, severe. Severe dysplasia has a 30% conversion rate into invasive cancer. So in a smoker, you need to be very careful with that. Obviously, you want to try and stop them smoking, but good luck with that. And unfortunately, this is a hemiglossectomy I performed recently. You can see the central tumor. And you can see with oral cavity cancer, it's a particularly aggressive subsite. And we have to do large margins on these and also do neck dissections. Here's another patient. You can see here, even though the neck was N0, nowadays for early oral cavity cancers, we do neck dissections. There's a 13% survival advantage, which we know from Tata Memorial in India. So this guy here, he's got a tumor at the side of the tongue. In the old days, we used to do these longitudinal resections, okay? Whereas nowadays we do these like a pizza wedge here, and we suture this part back here. Now you think to yourself, sure, that's going to be desperate. But just remember, like the tongue will be tied back. But the tongue is the only organ in the body that has a cranial nerve either side going into it. So what does that mean? It means that it recovers. It's smart. It's really smart. So I'll show you an example here. So here's the pizza slice. The first time I saw this technique was on a Broadway actress. And I remember saying to the surgeon, are you sure about this? And he said, yeah, no, wait till you see. So that's the way it looks at the end. So you're thinking, that's awful. But the tongue figures it out. That's the neck dissection there. So that's with the lymph nodes removed. There's the posterior biliodigastric, anterior bilious, mylohyoid. You can see here, that's the spinal accessory going down to the trapezius, jugular, carotid. And this is here, going underneath here is your hypoglossal nerve, the tongue. So here's the patient. This was 3 weeks after that surgery that you saw. It's funny, isn't it? You don't expect it, but it's just that the tongue figures it out. What was at the side is now at the front. The tongue figures that out. And it's just because it's just got such a dense neural input there. Of course, unfortunately, my patient didn't stop smoking, but he's actually doing really well. This is another lady. This lady was 93, came in, doubled over in pain, very smart lady, just in desperate pain. And basically the referral was to palliate. It's very hard to to effectively palliate, apart from just giving analgesia. You can't really give palliative radiation to a tumor on the tongue. Okay, it's difficult. She's not going to stay still. Whereas if you can just remove that quickly and using this wedge technique, you can get a good result. So with my anaesthetist colleagues, and obviously you need a really good anaesthetist, we did the surgery very quickly, and this is her 6 weeks later. Do we have volume? Do we have some volume there, please? Great. And how do you feel after your surgery?
I feel very well.
Okay. And how's your pain?
Pain, I have no pain.
And did you have pain?
I did have a lot of pain.
Good. And what about eating and drinking?
I'm able to eat and drink my fill.
Excellent. Well done. Good lady. There we go. Okay, so let's jump onto laryngeal cancer. Another beware. Beware dysphonia in a smoker during the flu season, because immediately we think it's just the flu. Okay, just dysphonia in a smoker, full stop. They need a scope. So just be very, very careful with smokers. There's your larynx there. So there's the epiglottis. The epiglottis is part of your supraglottis. People often think it's part of your pharynx. It's nothing to do with your throat. It protects the larynx. So that's your supraglottis. Okay, there's your false chords of the supraglottis. This is called the aryepiglottic folds. Okay, so if you have a child that swallowed a bit of Lego and you hear, that's supraglottic. That's stridor. That's an inspiratory stridor. The problem is that the Lego is in the supraglottis. Whereas if you have a tumor on the level of the glottis, and I'll hear this in my clinic about once every 6 weeks, before I walk into the patient, I'll hear, and we know we need to go to theatre. Okay, because that's a biphasic stridor, and the tumor's at the level of the glottis. Subglottis, then you're going to have an expiratory stridor, and then that extends down your trachea, which is about 12 centimeters in length, 2.5 centimeters in diameter in an adult. Okay? So most cancers in the larynx are in the glottis. They're at the level of the vocal cords. Fortunately, it has a very poor lymphatic drainage, so they rarely have cervical dissemination. Whereas the supraglottics could have a small tumor, but could have bilateral dissemination because the lymphatics link in with the base of the tongue. There's lots of treatments. The earlier we get these, the better. Laser microsurgery, which I particularly enjoy, and radiation, of course, two excellent modalities of treatment. Why do I try and do laser if possible? Because most of our patients continue to smoke and they will require radiation at some stage. So I just try to keep it in the back pocket, because once you radiate, you can't go back there. Thyroid cancer. We could have a full day talking about thyroid cancer, and what a mess we've made of it. Overdiagnosis, overtreatment. Does anyone know what's happened to survival in thyroid cancer in 40 years? Nothing. Nada. Not a single bump. What killed you 40 years ago kills you now. What's happened to thyroid surgery in the last 40 years? Off the charts. Okay? So it's a classic example of over-intervention. And that now is correcting itself. This was, we go back to the British. In 1858, they decided there was too many snakes around New Delhi. So they decided to tell the farmers, for the head of a cobra, we'll give you money. So the farmers decided to breed cobras to make some money. When the British found out what was going on, they rescinded the monetary reward, and at the end of it, you had more snakes than at the beginning. So that's called the cobra effect. An attempt to make a problem better makes it worse. And in relation to thyroid cancer, a desire to eradicate results in more disease. And this is what we've seen, this rise in papillary thyroid cancer. Most of it are small because of radiation, or because of radiology, ultrasounds, CTs, PET scans. We're just detecting more of what's already been there. Okay, there is no epidemic. So now we look for, this is the U value. This is what your radiologist should give you in terms of a thyroid nodule. If they're not, get a different radiologist. Okay, that's what you should be looking for, because anything U3 and above needs a needle test. I'll often get referrals about, oh, the thyroid nodule is big. So what? It's about what's going on in the nodule. The size of a nodule does not confer malignant risk. Nowadays, instead of just taking out the thyroid and giving everyone radioactive iodine, now finally there's a little bit of science that's attached to it. Okay, so there's still a degree of over-operating that goes on in Ireland compared to, say, the United States now, but that is gradually correcting itself. And instead, we focused on a risk-adapted paradigm. Are they truly at risk? Most patients in thyroid cancer, the vast majority are low risk, and their 20-year survival is 99%. This is one gentleman here, so you can see a large amount of lymphatic disease here. So that's following a total thyroidectomy and neck dissections. Okay, you can see the recurrent laryngeal nerve here. There's this trachea. There's on the left side, there's the other nerve there. It hugs between the trachea and the esophagus. You can see this is the carotid, the vagus, the jugular vein. They're splayed out because of the disease that had been there for so long, and that patient's doing very well. Finally, the oropharynx. So this is our gentleman earlier on. Why is he alive? Because HPV negative disease, that's the smoker drinker, chemical carcinogenic, littered with mutations. The more mutations the tumor has, the smarter it is. Whereas you can see the HPV one is, if you like, a dumber tumor. Give it a cytotoxic agent and it stops producing, or it stops multiplying and dies. So they do better, the HPV positive patients in the head and neck. The 16-18 variant are the main players, 16 being the main guy for an oncogenic driver, resulting in an invasive cancer. We've done an audit showing, and I use this to in part help HICWA include boys. We've seen a 37% increase in oropharyngeal cancer since 2009 to 2013. Of that, 46% were HPV positive. Of that 46%, nearly 80% were male. So that's the reason my boys have to be vaccinated. Okay? In fact, we will protect more girls by vaccinating more boys. We get more herd immunity. Is it safe? Yes, we're well beyond that discussion. To quote the Minister of Health in Australia, the jury is not out, the jury is very much in. So vaccination, however, yes, there's been great resistance to this. Most parents who don't vaccinate are not anti-vaccination Nazis. They are concerned, caring parents who are just wondering, are they doing the right thing? So rather than trying to ridicule, we need to just explain and educate. And thankfully the government listened, and we now have the opportunity to vaccinate boys and girls. So in conclusion, ladies and gentlemen, persistence of anything in the head and neck means that you need to have a higher degree of suspicion. Dysphagia, dysphonia, pain, globus pharyngeus, any bleeding, any skin changes, and any asymmetry that you're not happy with, in particular in the presence of a smoker drinker. And nowadays, too, anything in relation to the oropharynx, consider HPV in all age groups. Thank you very much.
So thanks very much. So again, we'll have some questions if you wait for the microphone before asking them. But I'll start off. Is there any age-specific range for head and neck cancers, or could it be anyone at any age?
So with these HPV patients, we're seeing a younger patient population who often don't necessarily smoke. So we're seeing, but we thought that they were, often non-smokers. Actually, as it turns out, a lot of the HPV patients do have a history of smoking, maybe up to 50%. But they're younger patients, and they don't necessarily fit into what our standard head and neck cancer patients would be, which would be smoker-drinker patients. In terms of the age profile overall, age used to be a big barrier. There was a paper that came out a few years ago that said over 65 they shouldn't get chemotherapy. Now that's rubbish. We have people who are 75 who are in a better condition than patients who are 45. So we really do it according to the MDT and look at the performance status of the patient.
Hi, Himayat is my name. I have two questions, if you can answer me. What is the prevalence of the unilateral tonsils, or tonsillitis rather, which is enlarged and it is recurrence in nature? Do we have to consider it urgent in view that it could end up in carcinoma? And my second question, you mentioned about the thyroid, that 99% survival rate is 20%. Does it imply to anaplastic thyroid tumor as well?
Okay, so the first question, anything unilateral I would be careful with. Any unilateral asymmetry of the tonsil, I would be very careful with. And
even if it is asymptomatic?
Yeah, even if it's asymptomatic, I still would be very careful with that. But I would be very careful in particular with your cervical nodal examination. So if you have a nice, smooth-looking asymmetrical tonsil, could that be lymphoma? More so with carcinoma, you're going to see mucosal breakdown. And you have someone who maybe has unilateral otalgia with that. But with the lymphomas, you may not necessarily have that. So just be careful and make sure you do a good examination of the neck, make sure there's no lymphadenopathy. And if you feel that possibly there is, well, then all the more reason to refer. In relation to your thyroid, you're absolutely right. So when we talked about the papillary thyroid cancers, which is the vast majority, and these patients do very well. By the way, probably a third of this room have thyroid cancer. 1.6 million Irish people have it, 100 million Americans have it. Okay? You know, that's just the reality of it. We know those from autopsy studies that have consistently, about 35% of autopsy studies, patients will have papillary thyroid cancer. So those patients generally will fall into a low-risk category. But you're quite right, who does die of thyroid disease? Because clearly there are a group of patients that do. The poorly differentiated, and as you said yourself, the anaplastic thyroid cancers. Anaplastic thyroid cancer in Ireland, I've done the review, a decade review of anaplastic, the mean survival was 4 months. And that would be internationally consistent. Reason why is that 50 to 90% of patients will have adjacent tissue invasion on presentation, 20 to 50% will have distant metastatic disease. There's very little you can do with them. And they unfortunately will frequently present with airway distress. So they're the ones but thankfully it's a rare disease.
I'm seeing for leukoplakias in recent times. They're in younger people, and they are, as you say, smoker drinkers. What can you do for them?
Yeah, it's a really difficult, I think education, number one, that you show them the white patches and explain to them that this is their body telling them that they're under stress. These are the areas of cellular stress, and within that they can have a pre-cancer. And I would have no hesitation saying to the patient, that could contain pre-cancer. Because once they hear that word, you may be able to get through to them, particularly a younger person, try and just snap them into reality to stop smoking. What can you do? It's very difficult. You know, we try and remove the aggravating factor, and that aggravating factor is smoking. That's the problem. But I think giving someone a lecture is not going to work, you know, because they pick that up as being patronizing or condescending. Just education, trying to educate them about the realities of this. But what I would do in that scenario is I would refer that in, because that needs to be biopsied. If it was a discrete area, I would remove all of it. The problem is often you'll find it's in multifocal. You'll see it's on the buccal mucosa, it's on the lateral tongue, there's a patch on the floor, and that makes it all the more difficult. And there are a lot of patients that we see this where they have this almost like field cancerization that we have to just observe, where they have these dysplastic oral cavities. We see it in the larynx as well, a dysplastic larynx, and we monitor them very closely. I'll scope them, you know, normally about every 3 to 4 months.
Do they invariably progress?
No, not necessarily. So with not every patch of leukoplakia has dysplasia, maybe about up to 10%, maybe a little bit more. So a lot of them don't have dysplasia, but of those that do, if it's discrete, we can remove it. So it's really just the ones where we find carcinoma in situ, that has a 30% conversion rate to cancer. So with a lot of the patients, we can do a lot for them. But sometimes it can be very frustrating. You know, more so when you've got patients who've got cancer history and are still smoking away. I've had patients who've had laryngectomies and they're trying to inhale through their stoma. You know, that's the reality of it. Saying, good morning, Professor. You know. Yeah.
Dr. Neil, thank you. Thank you very much for your...
How do we differentiate between lichen planus from leukoplakia? Are they both precancerous?
Good question. So the lichen planus is not really going to be associated with dysplasia, very, very rarely. But how would we dissociate histopathological assessment? It needs to be biopsied.
All right. Thank you.
Dr. Neil, thank you very much for your talk. How concerned should we be about the 30-something-year-old man, non-smoker, comes to the consultation with a persistent lymphadenopathy on the right side of the neck, completely asymptomatic, ongoing sore throat problems. And he has been through 2 different consultations on previous GPs, and they gave him reassurance that everything was fine. And he was extremely concerned about some kind of information. And I tried to give him some confidence. I wasn't quite sure what to do with him. So I referred him to the general surgeon to get probably a checkout, to have that lymphadenopathy to be checked out. I don't know if that's the right procedure for me to do as a GP, or maybe just refer to ENT. The biopsy will be probably the best option for him in this case, or ultrasound of the neck. So
well,
I don't know what's the
so
procedure should be.
there's two things there. So that patient has had multiple consultations about the same thing. So I'm concerned about the patient. I'm also, in the climate that we live in, I'd be concerned about the GP, because the problem is that there clearly is something going on. The concern would be that there could be a neoplastic process. And we have a blame culture. And when we get blamed, if someone gets recurrent disease, we'll often get blamed. And certainly when someone gets an initial diagnosis, people blame GPs. And we see that a lot. Oh, he gave me antibiotics for the last 3 months. It's like, yeah, that's what I would have done. So what I would do, the first thing is, I think you're right to refer in, whether it's general surgeon, but I think you need someone who's fellowship trained in the neck, okay? I wouldn't necessarily open someone's neck in that scenario, because an ultrasound-guided core biopsy will give you lots of information. So do full history, full examination. I would scope the patient, I would send off a panel of bloods, and I would get an urgent ultrasound-guided core biopsy. That would be my initial, and then from the result of that, discuss it. If there was a definite cancer diagnosis, okay, well then we go down whatever road that is, whether it's thyroid cancer or squamous cell carcinoma, et cetera, lymphoma, et cetera. And then we would get probably PET imaging of the body to see is there any disease elsewhere, discuss it in MDT, and move forward with therapy.
Thank you very much.
Well, my name is Dr. Cameron. I'm based in Donegal. So I have a question. While you were explaining about thyroid nodules,
yeah.
You said the size of the nodule, it's not matter. It's not directly linked with the if it's a benign or not. So my question is, in a community setting, how we would differentiate, because in the first consultation when the patient comes to us, what we do is we request TFTs and neck scans. If it's normal, so what we basically do is we normally do surveillance scans, just monitoring the size.
Yeah.
So I do have a patient now. She has got a big goiter, and it's intrathoracic, but it's completely benign. Right. And she's getting dysphonic, aphonic, and all this stuff. So when is the real indication for intervention, or if it's benign?
So I wouldn't take, if you have someone who has a palpable goiter, I would be slow to observe them yourself. I would look for assistance elsewhere, okay? The reason being is that you need the ultrasound not so much to tell you the size of the nodule, it's to tell you the ultrasonographic characteristics within the nodule. So if they write back to you with the report and they say there's a U3 nodule, okay, or a U4, which is highly suspicious, and a U5, which is where ultrasonographically they're saying I'm looking at cancer. Anything U3 and above needs a needle test. Okay? If that lump or bump, that patient says, it's the last 3 months I'm noticing this, and when I lie flat, it's pushing on me, and I'm a little bit breathless. And again, they're just sometimes from the sheer size, you're going to get an obstruction. Okay, that doesn't necessarily mean cancer, it may just be benign. But why has that come up so quickly? I certainly would want a needle test in that scenario to reassure me that nothing is going on, and a good ultrasound with a U value. The U values are, because what we do then is we correlate the U value with the needle test, which is a thigh value. So a U3, we'll correlate that, and I want to see a thigh 2 or a thigh 3A. Thigh 3F, thigh 4, thigh 5. Thigh 5 is where the cytopathologist is saying, I'm looking at cancer. A thigh 4 is they're saying suspicious, 80% risk. A thigh 3F is where they're saying there's about a 40% risk. So a thigh 3F and above needs surgery. So if I have I'm looking for concordance. If I have a U3 and above on the ultrasound, and I have a thigh 3 and above on the needle test, the patient needs at the very least a diagnostic lobectomy. Now, thankfully nowadays, say it is cancer, and it's in a young patient, okay? In the cancer setting, if it's below 4 centimeters, and I showed you there about 80% are under 2 centimeters, nowadays what we're detecting, that patient will need the lobectomy, and that's it. They do not benefit from a total thyroidectomy. And we know that from Jayton Shah's work from New York. Okay, so the extent of surgery does not confer a survival advantage. And what's the benefit for the patient? They keep their thyroid. And the focus nowadays is keep your thyroid. We don't want to take someone's thyroid out. How many times have you had patients in front of you, right, where their thyroid biochemistry after a thyroidectomy is normal, so their dose of L-atroxin is good, and you say to them, how do you feel? And they say, I'm wrecked. It happens all the time. So
what's the specificity of needle test? Because most of the time the lobectomy is probably
Very good question. So it's not great, and that's the reason why once we hit the Thi3F, we need to intervene. There are studies in the United States that have looked, we have where we look for certain genetic mutations in the aspirates, which may confer a slightly higher. So one of them is BRAF. You'll hear that in relation to melanoma. We also look for it in thyroid. And that may necessarily confer the higher risk to that aspirate. But is that used routinely in Ireland at this moment? No.
Thank you very much.
Excuse, sorry.
Sorry, can I just ask, you just mentioned that they've had their thyroid out and then their TFTs are normal, but they feel erect. So why is that?
Well, this is the thing, is that nothing is as good as your own endocrine organ. So biochemically, you're thinking to yourself, fantastic, they're on their 100 micrograms a day and everything is great. But then you ask the patient, how are you? And I'm not good. So we know there is nothing better than your own organ. So back in the day, we took everyone's thyroid out. But now that has stopped. And the only thing is that it just shows you how slow medicine sometimes is to accept good research. Jaden Shah showed that 20 years ago. And in Sloan Kettering in New York, they've been performing conservative thyroid surgery for 20 years. And it took that time before eventually everyone kind of went, okay, you were right. So for most patients, if they have a normal contralateral lobe and they have a papillary thyroid cancer up to 4 centimeters, they don't necessarily require a total thyroidectomy. Right. So it's a real change in philosophy.
Thank you.
Okay. Sorry, I think you've already overlapped with this, but I would have a few patients coming in that have health anxiety, and one of the symptoms they would come in with would be lymphadenopathy that has been chronic, very small lymph nodes, bloods are normal, examination normal, and it's been quite stable. Got an ultrasound, and it's not always reported as the U3, that grading. They would say it's probably fine.
Is for thyroid now or for cervical?
Just in general, so they would find, say, 1 or 2 nodes in their neck, and they're worried about lymphoma, worried about ENT cancers.
Okay.
They've been fully examined, and the scan might come back as probably benign, but clinical.
Sure.
Warranted.
Well, the ultrasound, when the U values are specific to the thyroid, okay, they're not for cervical lymphadenopathy. And the cervical lymphadenopathy you want to hear, do they think that there is a benign feature ultrasonographically, or is there? The thing is this, is that, will I go ahead and someone say I do a normal exam, okay, so what I would do there is, it's better for the two of us to be able to say to the patient, listen, we think you're good, okay? Yes, patients can, the one area that patients get fixated on is globus pharyngeus. There's just something in there, doctor. And you do a normal exam, you get a barium swallow, you do a rigid esophagoscopy, it's all fine, okay? It used to be called globus hystericus, because patients very definitely do get centered on that. So what do I do in that scenario? I do a full exam, normal scope, the ultrasound is reassuring. I probably would discuss it with my ultrasonographer as well, or my radiologist. I'm not going to do a needle test because someone's anxious. I'm not going to intervene because a patient says, well, I'm scared I have. You know what I mean? So if they want to go to someone else, you go do that. But it's wrong to just intervene because you're being pushed into it by a patient. So, I just think, look, if you need backup, you need a second opinion, then, call for that. I often have patients who have a cancer diagnosis, and I would really, really encourage them to get a second opinion. It's a really good thing. In Ireland, we feel second opinions as almost being rude to the doctor. Okay, it's not rude. It's in America, I'd be the 5th person that someone would come and see. It's routine over there, whereas over here people are, but a second opinion is a good thing. There's nothing wrong with it. And it protects the patient, and it protects you and me as well.
Thank you.
Would you see many cases of sarcoidosis being referred to as being queried?
Great question. So certainly sarcoid, we would see sarcoid, okay, and we would see sarcoid in the neck, and you'd see this non-caseating on your pathology. You remember that classic non-caseating granuloma, as opposed to a caseating granuloma that you'd see, the caseating cheese-like tuberculitic abscess. So we would do that. We would test for sarcoid as well. We do see it on occasion, and then we'll refer appropriately. So good question. Sorry, I didn't bring up sarcoid. We would see it on occasion, and certainly it's part of the differential.
Okay.
Thank you
Thanks
very
much. So we're going to take a 10-minute coffee break. If you want to go out and get a cup of coffee, and I think there's also a raffle going on. If you want to get a ticket, we'll do that. And see you back in 10 minutes. You're welcome to bring the coffee back in.
Yeah.
Yeah, she's great.
Oh. So welcome back. Welcome back after the coffee break. We're going to have our next speaker now. Our next speaker is Dr. Rory McQuillan. Rory McQuillan is a consultant nephrologist. He specialises in managing patients with multimorbidity, hypertension, diabetes, chronic kidney disease, heart failure, electrolyte disorders, and TIAs. He's operating out of the Blackrock Clinic at the minute, and he's going to give us a talk about hyponatremia and electrolyte abnormalities. So thank you, Rory.
Thank you very much for the introduction, and thank you all for being here this morning. I'm just going to focus, in the interest of time, on hyponatremia this morning, and leave the other electrolyte disorders for another day. Hyponatremia, as you're aware, is the most common electrolyte disorder that we see, both in general practice and in the inpatient population. In the patients I look after, probably between 30 and 35% of them will be hyponatremic at some point of their hospital stay. In the community, you're looking at between 15 and 25% of the over 65s will be hyponatremic. So the objectives for my talk today, just a couple of things that I want to cover. The first is to go through the different patterns of hyponatremia that we'll see. And really, hyponatremia, I hope to convince you, falls into one of two different patterns, either acute symptomatic hyponatremia or chronic asymptomatic hyponatremia. So we're just going to show you two cases just to differentiate between the two of those. And we'll use that then sort of as a jumping off point to talk about a clinical approach as to the diagnosis of hyponatremia, and then we'll talk about a couple of the different features in managing the different types of patterns of hyponatremia that we'll encounter. So this is a real case. This is a lady who I saw. I worked for about 10 years in Toronto General Hospital before I started in Blackrock. This is a lady that I saw in the emergency room there, and she's a 58-year-old woman. She was originally Korean speaking but fluent in English, and she was brought to the emergency room by her husband, who found her to be increasingly confused to the point where she could no longer speak English. She had reverted to speaking Korean. So it was quite an unusual sort of presentation. And her story was that she'd had a dental procedure 48 hours previously. The procedure had been complicated by very severe pain. She was taking a lot of morphine. She was taking an antibiotic prophylactically, which had made her nauseated. And she presented, as I said, with this confusion, loss of one of her two languages, disorientation, extremely agitated to the point where I saw her. She had actually had to be in restraints to stop her from hurting herself. And the real standout feature on her bloods and admission was a sodium of 115 millimoles per litre. So this highlights one of the two different patterns. This would be acute symptomatic hyponatremia. Her sodium, we didn't have one in the last 48 hours, but it was historically known to always be normal. The woman was completely healthy, on no other medications. So acute hyponatremia is a life-threatening medical emergency. And what happens in acute hyponatremia, and why it's so dangerous, is that you get a sudden drop in the plasma osmolality. So usually due to a combination of water intoxication and or excess antidiuretic hormone, you develop an excess of water. What happens in that situation is that water will move from the intravascular space into the cells, because the osmolarity as your sodium has dropped, and water moves to equilibrate across the cell membrane. So that's not a problem in most of the cells in your body. However, it is a problem in your brain. So as you can imagine, as water moves into the cells in the brain swells up, and the brain only has a finite amount of room to expand into. So as your brain cells swell, eventually it reaches the barrier, your skull. The brain has then no further room to expand, and eventually what happens to these people is that they progress through a neurological series of sort of neurological syndrome to eventual cerebellar tonsillar herniation or coning. That's what these people die from. Who would you think is more at risk of this? Would it be young people or old people? Young people, yeah, exactly. So young people, older people are relatively protected from tonsillar herniation from hyponatremia because there's more room in their skulls. So you get cerebral atrophy as you get older. People that die from acute hyponatremia tend to be young. So the classic one is the teenager who's been out, has taken an ecstasy MDMA tablet that induces ADH. They also become hyperthermic, profoundly thirsty. They drink a lot of water and they present with low sodiums acutely and can get into trouble with seizures, and if not treated, ultimately death from this mechanism. This is what you see on a CT of brain of somebody who's acutely hyponatremic. So I've been asked to use the mouse rather. So this is a normal CT brain, and you can see the normal pattern of the ventricles there, whereas you're getting ventricular effacement in the patient with hyponatremia. You see also the loss of the sulci here on the scan on the right with hyponatremic. As the brain swells up, you lose the sulci. And then finally, loss of grey-white matter differentiation. So when you're faced with somebody with acute hyponatremic, your clinical priority is to stop this syndrome. So as I said in the last point on this slide, the need to rapidly reverse the symptoms associated with acute hyponatremia, which will be confusion, lethargy, agitation, progressing to seizure, ultimate coma and death. The need to rapidly reverse those symptoms overrides a concern that we might have about correcting sodium too rapidly. So what you want to give in this sort of situation is hypertonic saline. Hypertonic saline is quite a safe thing to give, and it's really the only thing that will do the job in this situation where you have acute symptomatic hyponatremia. So the usual principle in treating acute symptomatic hyponatremia is that you give enough of the hypertonic saline until the symptoms resolve. So you don't have a limit into how quickly you can reverse the sodium. You want to give them the hypertonic saline until their symptoms abate. It's actually a very satisfying thing to treat. It's similar to treating somebody who's hypoglycemic. It's like a light switch. Their symptoms will stop when you bring their sodium back up to a normal level, or at least to a level whereby their brains are able to accommodate. So hypertonic saline, if you're ever needing to give it, comes in 250 cc bags. Typically, for your average sort of 50 to 70 kilo person, somewhere between 250 cc's of saline will suffice to bring their sodium up by the amount necessary, around 5 millimolars, to correct their symptoms. We typically don't give this as a slow infusion because, again, the thought is that you want to rapidly correct the sodium. So you give your bolus of saline, you work out how much you think you need to give based on the person's size. You give the bolus of saline. If their symptoms aren't better, then you repeat, and you keep repeating it until the symptoms have gotten better. What we see more frequently is chronic asymptomatic hyponatremia. Now, one of the things which I find confusing, I think a lot of people find confusing about this, is asymptomatic hyponatremia. Hyponatremia may not be truly asymptomatic. When they talk about asymptomatic hyponatremia, they mean not acutely symptomatic, having seizures and going to die. Asymptomatic hyponatremia is a bit of a misnomer because people who have chronic hyponatremia will have some symptoms. They may feel tired. They may have a little bit of nausea. They may not just be sort of quite right in terms of their balance, but certainly they don't have the same kind of abrupt and very dramatic presentation as in the first case. So this is a 74-year-old lady who attends her GP complaining of low energy and poor balance. She was ultimately sent into the emergency room, but her background is of hypertension, and she's felt that she drinks a bit too much alcohol, and she'd been started on codiavan, which is a combination of an angiotensin receptor blocker and a thiazide diuretic 3 months previously. Her examination was unremarkable, really not anything particularly obviously wrong with her, but on routine blood she's found to have a creatinine of 40, which again would be, you know, in keeping with her frailty and perhaps, you know, poor oral intake, a sodium of 115 and a potassium of 2.5. So this is somebody with chronic, minimally symptomatic hyponatremia, and the treatment strategy and the treatment goals here are very different from in the first case. So I just want to take a little bit of time just to talk about what happens in your brain over time when you're exposed to hyponatremia. So the situation on the left shows what happens in acute hyponatremia. So excess water comes in when your sodium drops into the cells and they swell up. Your brain cells are clever though, so if left to their own devices, what they will do is they will start to dump osmoles out of the cells to resist that. So what happens over the first couple of hours is this sodium-potassium channel starts to dump sodium and potassium out of the cell. If you go and do a lumbar puncture in somebody who's been made hyponatremic, you'll see a spike in the electrolytes in their spinal fluid within minutes of the person becoming hyponatremic. So the brain is quite clever in that sense in trying to resist these forces on its volume. What happens after a couple of hours, and which is sort of complete after 48 hours, is that as well as dumping electrolytes out of the cells, the brain will also dump other organic compounds out. So these are amino acids that it will dump. So proteins, it will offload these proteins into the cerebrospinal fluid. That's extremely important when you come to thinking about chronic hyponatremia. You've basically now have a brain cell that has gotten rid of proteins out of its intracellular component. Those proteins can't just go back into the cell. They have to be remade. So the problem when you're treating chronic hyponatremia is that if you rapidly correct the sodium back to normal, that cell has nothing to hold water in it. So the water will leave the cell and there's nothing to hold it in there. So you get this shearing injury to the brain cell or osmotic demyelination. So that's why when we talk about chronic hyponatremia, if you read anything about this, they give this idea of 48 hours. So if the sodium has been low for greater than 48 hours, it's assumed to be chronic. The reason is because after 48 hours, the brain has dumped all of these amino acids out of it, and it is very, very vulnerable to this shearing injury when you try to correct the sodium back to normal. So osmotic demyelination syndrome is actually more common as a sort of a cause of neurological sequelae than is acute hyponatremia. So we see more people damaged iatrogenically by our attempts to fix their sodium than we do people actually damaged by acute hyponatremia. The problem with it is that once it happens, it's largely irreversible. And it's a neurological symptom of dysarthria, dysphagia, confusion, paresis, in its worst state, leading to a locked-in syndrome, and it is caused by over-rapid correction of sodium in somebody who has chronic hyponatremia. Doesn't occur in acute hyponatremia, only occurs in chronic hyponatremia. The patient that I presented to you is perfectly set up to get osmotic demyelination syndrome. So the type of factors which predispose to osmotic demyelination syndrome are basically what I described in that lady. It's somebody who is malnourished, and if you think about it, that makes sense, because what predisposes the cells to injury is if they're not able to make more proteins to hold on to water within the cells. So somebody who's malnourished, somebody who's older, somebody who's frail. Alcoholics are particularly likely to develop osmotic demyelination syndrome. And again, it creates a treatment conundrum, because you'll have somebody who comes into the emergency room, maybe acutely intoxicated. It may not be picked up that they're chronically hyponatremic. So it tends to be the most vulnerable people that are most at risk of this. Hypokalemia, again, probably because it's a marker of malnutrition. The point on the top, the severity of hyponatremia, is important. You don't really need to worry about osmotic demyelination syndrome in people with sodiums greater than 120. So it's people who have sodiums less than that. It's never been described in kind of mild to moderate hyponatremia. So in terms of how we would treat this, second case, the first thing, again, just to stress, is that this person with her sodium of 115 is at far exponentially more risk from osmotic demyelination syndrome than she is from having a low sodium. The low sodium is, perhaps her poor energy and her poor balance are due to her low sodium, but that's not going to damage her. So you're really in no rush to correct her sodium. What you have to be absolutely certain of is that you don't correct her sodium, that you don't do something which will rapidly fix whatever is causing her low sodium and lead to her developing this osmotic demyelination syndrome. I'll just say a couple of words about that. The case I described is basically due to thiazide diuretic. That's one of the more common reasons somebody would be hyponatremic, particularly an elderly person, particularly elderly women. The problem with treating hyponatremia in somebody who's on a thiazide diuretic is that it's really easy to treat. So the people that get into trouble with overcorrection isn't somebody who's got like severe heart or liver failure, because you're not going to be able to fix that. It's somebody who is hypovolemic, perhaps because of a thiazide diuretic. Once you stop her thiazide diuretic and give her a litre or two of saline, her sodium will rapidly correct. So these are the people that get into trouble. The care with administration of normal saline and the monitoring of urine output bear some discussion. A lot of people worry about the volume of saline that they give the patient, or the concentration of saline. That actually doesn't matter all that much. If you think of somebody like, even a small person, their total body water is usually about 50 to 60% of their weight is going to be 30, 40 litres. You putting a litre of saline in on top of their 30 or 40 litres actually has a negligible effect. If you work it out in this woman, if we say she's 50 kilos, it'll probably bring her sodium from 115 up to 117. That's not what causes the problem. What causes the problem is that in this person who's hypovolemic, you're able to shut off the source of excess ADH. So you give a litre of saline, you turn off her excess ADH production, and all of that water that she's stored up, what she's going to do, she's going to pee it all out. So actually what you need to monitor is the urine output. So this person, when you correct their hypovolemia, will have a free water diuresis. They'll dump 2 or 3 litres of water out, and then their sodium will rise from 120 to 140 in no time at all. So where this is a problem is the person that's sent into emergency, dry, off their feet, elderly person, they're seen in the emergency room, they go, well, she's dry, we'll give her some fluid. So she has bloods taken, she gets a litre of fluid, feels a bit better, gets another litre of fluid, at which time the bloods come back, go, well, the sodium's low, we better repeat that, and the sodium's gone from 115 to 140. That's where you get into trouble. It's giving elderly hypovolemic people fluids in a non-emergency setting without knowing what their electrolytes are. So that's kind of that's the issue. That's where sort of the kind of the medical legal issue arises with treating chronic hyponatremia. One of the things which I came across in Canada, which I hadn't been, I was called at about 3 in the morning when I went over there to do a fellowship first, and they said, this person's come in, her sodium's 108. I said, okay. And they said, we're going to give her some fluids. I said, great. And they said, we're going to give her DDAVP first. So DDAVP is basically antidiuretic hormone. So I sort of said, well, that seems counterintuitive. Why would you do that? Because, if you're thinking the person's problem is they've got too much ADH, and if anything, that's going to make them the matter worse. The logic in that is that if you've got somebody who is hypovolemic, volume deplete, and you want to give them fluid because they need it, say because their blood pressure is low, because they've got acute kidney injury, what you don't want to happen is when you give them that saline that their sodium rapidly corrects. So one strategy for treating chronic hyponatremia is that you give them exogenous ADH and then give them fluid. And what the ADH does is it allows you to safely give them the fluid and stops them from rapidly correcting. Because remember, they're not actually in need of correction of the sodium. What they're in need of is volume, and then you managing very slowly the correction of their sodium. So while it's a counterintuitive thing to do, it actually is very effective in managing the rate of correction in chronic hyponatremia. And finally, going slowly. So if you have somebody with chronic hyponatremia, there really is no safe rate. We used to be taught that 12 millimoles in 24 hours, then they reduced that down to 8 millimoles in 24 hours, and that's been now reduced to 4 to 6. I was involved in a case where a chronic alcoholic was brought into hospital, happened to die in hospital, but he died from something else. But while he was being treated, he became hyponatremic, and his sodium was managed back to normal in a absolutely textbook fashion. It was corrected like 1 to 2 millimoles per day. When they did his post-mortem, they looked at his brain. They found irrefutable evidence of osmotic demyelination, pontine myelinosis. So I think really what I said about the risk factors, the chronic malnutrition, you've got to be super careful in those people when you're correcting their sodium. So this is probably in terms of like the talk. This is kind of the most important slide. This is a diagnostic approach that we can use for somebody who has low serum sodium, and basically it's based on 3 different tests: serum osmolarity, a urine osmolarity, and a urine sodium. And I would argue with those 3 tests that you'll be able to tell with a fair degree of accuracy what's going on with your patient. I prefer this to the volume-based one because, sorting euvolemia from mild hypovolemia or mild hypervolemia is often difficult, not entirely objective. So I think this gives you a more objective approach. So the serum osmolarity, this is fairly easy. If your sodium is low, you're expecting your osmolarity to be low as well, because sodium is the main determinant of your plasma osmolarity. If your serum osmolarity is not low, it means you have a factitious hyponatremia. The usual one that we would see with this would be a high sugar. Obviously, if you've got a diabetic person, glucose isn't able to get into the cells because there's not enough insulin. If glucose can't get into cells, you have a high glucose, water comes out of the cells and dilutes the other osmoles that are in the extracellular component. So it's a dilutional hyponatremia, which will be made better by giving the person insulin and driving glucose into the cells. Similarly, mannitol will have the same sort of effect. It's osmotically active, draws water out of cells, dilutional hyponatremia. So it's important to check the serum osmolarity just so you don't subject the person to further unnecessary testing or treatment. In the vast majority, serum osmolarity will be low. So what you want to do then is check the urine osmolarity. If you think about it, urine osmolarity in somebody who's got low sodium, if they were able, as is the case here, to excrete a dilute urine, so to excrete water, in most cases they won't have become they shouldn't have become hyponatremic in the first place. So this is less common. This occurs in polydipsia. Now, polydipsia is also called psychogenic polydipsia. You rarely see this. This is somebody who drinks so much water in a day that they overcome the kidney's ability to excrete water. So it's generally seen in schizophrenics. They will, if given, they're usually in residential care, these patients, and they are known to have psychogenic polydipsia. So they've usually done it before, and what you have to do is basically make sure they've no access to water, including toilets. Like they have this psychiatric compulsion to drink water, and they will drink 10 or 12 liters of water, have a seizure, and be brought into hospital if given access to water. Beer drinkers' potomania is an interesting concept which I'm going to talk about on the next slide. For most people, the urine osmolarity is not going to be low, it's going to be high. So these are people who have an inability to get rid of water, and that is why they have become hyponatremic. So in these people, you can say that excess ADH is present. What you want to do is decide, is the excess ADH physiological or is it pathological? If the urine sodium, which would be the third test you would do, is less than 20, that person is either dry or thinks they're dry. Their kidneys think they're dry because the kidneys are doing what they're appropriately meant to do. So if somebody is truly volume deplete, they will be holding onto sodium, and you'll be able to say, right, this person is hypovolemic, hyponatremia, and you can treat it accordingly. That's important because, as I said, if that's a chronic process, these are the people who you can actually fix. Often, in a lot of the patients that I will see, the low urinary sodium will not be due to true volume depletion, it will be due to effective volume depletion. So people with heart failure or liver failure. So you can imagine if you've got very severe heart failure, your cardiac output is low, so your kidneys think that they're dehydrated because they're just not getting enough blood supplied to them. These people, you don't need to worry so much about overcorrection, but it is important to understand the etiology of their hyponatremia. The importance of the hyponatremia in heart failure, liver failure is really that it's a prognostic indicator for how the person is going to do. typically very difficult to fix. The other category then is where the urine sodium is greater than 20. So these would be people like in the case we described who've been on a thiazide diuretic, or people with SIADH. SIADH is basically where you've got somebody who's got a fixed, highly concentrated urine inappropriately from too much ADH. There is a long list of reasons why you might have antidiuretic hormone, excess antidiuretic hormone, from drugs to intracranial pathologies to lung disease. It's important that with anybody with low sodium that you check the TFTs and the cortisol levels, because in a lot of cases, while I've put them in with the greater than 20, they may have intermediate sodium levels depending on their hydration status at that particular time. So this algorithm here will allow you to allows you to have a diagnostic approach to work out what's going on with your patient when faced with somebody with low sodium. The beer drinker's potomania is a very important principle in diagnosing and in treating your patients. Beer drinker's potomania itself, you're not going to see a lot of, but it explains also what's going on with the patient with a low oral intake, somebody on a tea and toast diet. So generally, most of us in this room, if we look at it, will consume between 600 and 900 milliosmoles of solute per day. That's mainly coming from animal protein, from salt. So that then, if we're able to dilute our urine down to 100 milliosmoles per kilogram, gives us a fair amount of water that we can drink and get rid of. The important point here is that you can't pee out pure water. You have to have some osmoles in the urine. So if you don't drink, if you don't eat very much, that reduces the amount of urine that you're able to get rid of in a day. So for most of us, if we're taking 600 or 900, we're never going to get into trouble, because that allows us to get rid of 6 to 9 litres per day. If, however, you only consume 200 milliosmoles per day, how many litres of water can you get rid of? 2. Yeah. So hence the beer drinker's potomania. This is somebody who spends all their money on beer. They're able to live on beer sort of from a caloric point of view, but beer doesn't really have any effective osmoles in it. So they consume very, very little osmoles and a high volume of water, and they become inexorably hyponatremic, and they develop this potomania, this manic symptom. As I said, not important of itself, but very important in your elderly patient who may maintain a reasonable volume of fluid, but is not eating very much. That person is set up to become hyponatremic. In terms of treating SIADH, which is extremely common, I'll come back to the exacerbating factors in a second. One of the things that comes up is salt tablets and urea. These strategies are minimally effective. And I think it's important just to understand what it is that you're doing with salt tablets, and it relates back to the concept of beer drinkers' potomania that we've just introduced. Salt tablets of themselves, it's not that you're giving the person sodium and driving their sodium up with the volume of sodium that you're giving. It's that you're giving them extra osmoles, therefore necessitating that they get rid of that extra salt load in the urine. So salt tablets would work just as well as getting that person to eat more. And the same person that's not able to eat more is not going to take 9 grams of sodium a day for you. So it may not be a very effective strategy in treating somebody with chronic hyponatremia. Urea is the same principle. It's the same as giving them food. It's basically just giving them protein. Urea crystals are horrible to take. They basically taste and smell like urine. So it's a difficult thing to sell to people. So if at all possible, all you're doing with these strategies is giving the person more to eat. You're as well off as sort of giving them dietary supplements, high protein supplements. Water restriction works if you are truly dealing with SIADH. Water restriction does not work if as we said in the previous slide, if you're dealing with somebody who's volume deplete, water restriction is not going to do anything for them. So water restriction will only work for this group down here, the people that have an excess of water due to excess antidiuretic hormone. Water restriction also difficult to adhere to in the long term. I guess the point with all these chronic mild hyponatremias, the people who have got like sodiums 127, 131, is that most of those people over time, they tend to be elderly people with cerebrovascular disease. Most of those people over time come into their own equilibration, so they develop this thing called a reset osmostat. So in other words, they will maintain their sodium between 127 and 129, as opposed to 134, 136. I do not want to say that there's no harm to them of having the sodium 127, 129, because there is. Their balance isn't as good. They're more likely to have pathological fractures. However, as in many things in medicine, just because it being low is bad for them doesn't necessarily mean if you can bring it up to 132 that you're doing any good. Any of these strategies, water restriction, salt tablets and urea, and tolvaptan, which is a more expensive way of doing the same thing, they've been shown to increase the sodium, but they've not been shown to have any clinical endpoint result. So I think probably for most people that you see with mild asymptomatic hyponatremia, the correct thing to do is to monitor and do nothing. Okay. So this is a summary. Acute and hyponatremia are very difficult clinical entities requiring different clinical approaches to management, as I hope I've shown you. We've spoken about osmotic demyelination syndrome, and as we've just said, it may not be appropriate to aggressively treat mild chronic hyponatremia. Thank you.
So we'll just have some questions. I might just ask you a quick question, Rory. You mentioned that women were more likely to get hyponatremia on thiazide diuretic than men. Is there a reason for that?
No, not that I know of. Yes. There's a microphone here.
Is there a place for diorlite orally in chronic hyponatremia?
Not really, no. I mean, yes, insofar as it may get more osmose into the person and may force them then to get rid of more water. Anything that you can get that's nutrition into the person with chronic SIADH will help them to get rid of water. So there's a role for it in the same way as there would be a role for collagen or boost or any supplement. It's a way of getting osmose into them such that it makes them get rid of water. So it may be a useful strategy, but it will be limited by the same things as limited in all of them. The reason they're hyponatremic in the first place is because they don't want to or they can't eat.
Hi, Rory.
Excuse me.
Down here. How you doing? I have two questions to ask you. One is about chronic, both about chronic hyponatremia. Obviously, if we're putting up drips and all that sort of stuff, we're going to be referring on, okay? So in the chronic, the elderly woman, weak, malnourished, slightly malnourished, do you have a sodium level that you think we should be referring on to, or what's the criteria for referring on?
Yes, certainly less than 120, I would definitely refer. If it has dropped acutely from a baseline, say 130, 131 down to 122, 123, I would drop that. So basically, if it was anywhere more than 5 millimoles off their baseline, they may get acute symptoms related to that. If you're confident that you've seen this person month in, month out, and her sodium is always 125, there's little to be said for referring that person for inpatient correction.
Okay, and the second question is a bit off topic. But seeing you mentioned Codivan there, can you just mention a bit about ARBs and renal failure, and both in causation and what we should do in chronic renal failure?
Happy to, as you will remember, up until about 10 years ago, we were told, and this was from pharmacy supported by clinical trials, to certainly people who had kidney disease, that there was a benefit from combining different forms of RAS blockade, so combining with ACE inhibitors with angiotensin receptor blockers. It's been touted as a treatment in diabetic nephropathy, anybody with any kidney disease, certainly proteinuric kidney disease, and it then kind of came into the mainstream control of antihypertension. That was then debunked by the On-Target trial in 2009, which showed that actually what you were doing by aggressively RAS blocking people was increasing their risk of having acute kidney injury, of needing dialysis acutely, and there was no real survival benefit from it. In terms of using ACE or ARBs to treat hypertension, I still think they're good drugs. They obviously have pleiotropic effects in terms of they're good for the cardiovascular system, good for the heart, good for the brain. And in terms of the kidneys, they do have a renoprotective effect. You have to trade that off against the fact that acutely they will make your creatinine go up by about 30%. My practice in the general population is to use them. I would check a UNE typically 2 to 3 weeks after I've commenced the patient on the ACE or the ARB. I continue to use the ACE or the ARB all the way down to a GFR of 15, which is end-stage kidney disease, assuming that there isn't a sudden increase in creatinine of more than 30%. There's special populations that you can't use ACE or ARB in. If you see more than a 30% risk of more than 30% increase in creatinine, you've got to be suspicious for renal artery stenosis, particularly bilateral renal artery stenosis. With regards to potassium, I would generally continue them on an ACE or an ARB up to a potassium of about 6. If the potassium goes above 6, I would stop it at that point. Is there anything else you? Okay, yeah.
Okay, my question is regarding sodium correction in community setting, because whatever you were telling, it was in the hospital.
Yeah.
So normally what we do, basically, a patient with a mild or moderate hyponatremia, what we do is we prescribe slow sodium and fluid restrictions.
Yeah.
So my question is, should we really worried about ODS and how we should monitor? Because when we say fluid restrictions, how we calculate the how much water a patient should restrict? Because normally they ask doctor, what do you want me to drink and what not to drink? Yeah. Should we check in the urine osmolarity and all that stuff?
Yeah, I think you probably should. It depends on how sort of barn door, if you like, the SAADH is. If you're treating somebody who's hypovolemic with fluid restriction, obviously that's not going to work. Because if you've got somebody who's got like who's been on a diuretic who is hyponatremic because their volume deplete, then fluid restricting them is the last thing you want to do. In somebody who has SIADH, treating them with water restriction is a safe thing to do. The sodium pills, I would be cautious in using them with sodium below 120. The reason for that is that if you believe they work, then they should, and if the patient as an outpatient will never take them, but if they did actually take them, it could cause a diuresis and it could cause a rapid correction of the sodium. In practice, as a strategy for correcting sodium, it doesn't work all that well. So you're probably safe, but if you were actually prescribing it to somebody presumably with the thought that it was going to work and the sodium was less than 120 and you thought it was chronic, you probably shouldn't do it. Greater than 120, likely no risk.
Okay, thank you.
Hi, I'm here.
Hello, yeah.
In your second last slide, you mentioned one thing, tolvaptan.
Yes.
What is tolvaptan?
Oh, yeah.
And my second question as well, but second question is that patients who we treat them with diuretics for, say, congestive cardiac failure, presents with leg swelling. If we gave them the diuretics, they go into hyponatremia and their leg swelling gets better. Yeah. If we do not give them the diuretics, although we are concerned about that, the sodium level will not go down, but the leg swelling will still be there. Yeah. So we are going into a circle.
Yeah, absolutely. I'll answer the first question first. So the first question was, I mentioned tolvaptan, but didn't expand on it in my talk. Tolvaptan is a drug which blocks the aquaporin channels in the kidney. So basically, it's like an aquaretic. It stops your kidneys from reabsorbing water, and it works brilliantly at doing that. So if you've got somebody with chronic SIADH and you really want to bring their sodium back up to normal, tolvaptan will do the job for you. But it's expensive. You're talking about 90, 100 euros a day for the drug. It has side effects. You have to monitor the patient's liver function test because they're going to be on it chronically. Finally, when you've brought their sodium back up from 125 back up to 135, it has not been proven to actually have any clinical benefit. It corrects their sodium beautifully, but there's no clinical outcome that has been shown to improve. So for that reason, it hasn't been licensed for the treatment of hyponatremia. You are, however, going to see it more because it has been licensed for the treatment of polycystic kidney disease. So the thinking of polycystic kidney disease is that the disease is these fluid-filled cysts in the kidneys. Tolvaptan greatly reduces the rate at which those cysts form, and it reduces the volume that they reach. So the trials done on this showed the total kidney volume over 3 years on people with tolvaptan versus placebo much smaller. So the thinking is that if you have somebody who's at high risk of progression to end-stage kidney disease from polycystic kidney disease, they would benefit from treatment with this drug tolvaptan. Has been licensed for that in Ireland, so you will start to see it in that setting. The problem is knowing who to give it to, because obviously, if your father got to the age of 70 without needing dialysis, if you've been diagnosed with polycystic kidney disease at the age of 30, are you going to take a drug which could potentially harm you for the next 40 years for questionable clinical gain? It's a nuisance to take because it causes an obligate, it's like giving the person diabetes insipidus, it causes an obligate sort of 5 to 6 litre per day diuresis. So that's tolvaptan. The second part of your question was about low sodium and heart failure and treatment with diuretics. I guess the first thing to stress is that furosemide, because of where it works in the nephron, does not of itself cause hyponatremia. Thiazide diuretics, because of where they work, do. So if you put somebody on a thiazide diuretic, they may not even be clinically obvious that they're volume deplete. But they can develop hyponatremia. The reason for that is that it drops the blood pressure and the circulating volume ever so slightly. That triggers ADH, and because you've left the loop of Henle where the Lasix works alone, they still have lots of concentrating ability in their kidneys, so they're able to suck water back out of the tubules. So you now have a setting where you've made them slightly volume deplete, but they still have all this concentrating ability in their urine, so they avidly reabsorb water and they become hyponatremic. If you put them on Lasix, it actually is a strategy for treating with the salt pills. You can give them Lasix at the same time because you wash out that concentrating ability and stop them from reabsorbing water. So Lasix of itself will actually resist hyponatremia. Lasix will only cause hyponatremia if you make the person profoundly volume deplete with the Lasix, which you might do in the treatment of heart failure. The problem with treating heart failure, like either acute kidney injury, cardiorenal syndrome, or hyponatremia, is that, as you say, it's a circle. If they're too wet, they get into trouble with kidney failure. They get into trouble with low sodium. If you make them too dry, they get into trouble with the same things. So the question, the difficulty in managing hyponatremia is in managing heart failure is to try to get them in this sort of very small window whereby their hemodynamics are happy, and that's why we need heart failure clinics. That's why people invest in infrastructure to monitor the patient at home with their weights, because it does, as you say, it's very difficult, kind of a circular relationship, and requires in hitting that very small sweet spot, which becomes increasingly small as a person's heart failure advances.
Thanks, Dr. Rory. Yeah. No, can you? Okay.
Yeah.
Okay. I have two patients in the practice. Those are the kind of special patients with special needs, mental disability and epileptic conditions, and on carbamazepine on the longer term treatment.
Yeah.
And it's widely known that carbamazepine causes some kind of a hyponatremia.
Yeah.
His levels of sodium has been consistently low, from 125, 122, and the lowest has been 118. How long can we just resist, or what will be the desired level until we do something? Because as I recall from one of the latest slides that you showed, probably the salt tablet wouldn't do that much good on them, and the tolvaptan is unlicensed.
Yeah.
So what will be the best approach in this patient?
How bad is his epilepsy?
Definitely, he has been quite bad. This issue has been addressed by his neurologist.
Yeah.
He's been trying to just reduce the dose of the carbamazepine with the opposite side. So the convulsive state has even worse.
Yeah.
So we had to back up to his previous level. So he has to definitely needs to be on carbamazepine on a higher dose.
Yeah.
Which I don't recall.
I would. I mean, just obviously, it depend on seeing the patient. Everything goes without saying. But I mean, from the sound of that, he sounds like you've tried other strategies in terms of introducing other drugs. They're not controlling his seizures. If you try to reduce the dose of this drug, he gets seizures. If you can keep the sodium in the mid 120s, I would persist with the drug on the basis that he's at more risk of having seizures than he is from his mild chronic or his moderate chronic hyponatremia. I guess it's also very difficult to sort out which of his neurologic symptoms are due to his epilepsy, his developmental delay, and then his hyponatremia. So it's a very difficult case, and I don't have a good answer for you.
Okay, he seems to be on control. He seems to be with a good control of his seizures.
Yeah.
And apart from that, from his low sodium, he seems to be asymptomatic. So I don't know, we should be just leave it that way?
From what you've told me, I would leave it that way, but
thank you.
I have a 50-year-old patient who's on methadone, and he was giving me urines that looked suspiciously dark, and I checked a specific gravity and it was 1.
Yeah.
And he vociferously protested that it was freshly passed on the premises. But I was wondering, should I send a urine for sodium or osmolality or what? Because I'm sure it's tea or something else.
Sorry, so just say the last bit again?
I'm sure it's tea or something else.
Okay.
It's not urine.
I guess
it's the specific gravity of one is not.
I got you. So you're saying he's adulterating the urine with something else. I guess creatinine would be the best thing to check. There are if he's diluting the urine by more than sort of 10% or more than 20% with something that's not urine. It will be obvious from the creatinine in the urine that the concentration is just off. So you're going to get something in millimoles or in micromoles that comes back in the tens of thousands. If you get something in the hundreds, then it's not urine. So it's the same principle as we would use. It would be these people that after urologic surgery develop collections, and we're trying to work out whether it's urine or whether it's something else in the collection. We do a creatinine on that fluid sample, and if the creatinine comes back in the right kind of 10 to the power of, we say right, it's urine. Whereas it comes back as a much lower number, we say okay, well this isn't urine. Yeah.
Just in the interest of time, maybe we might ask Rory some questions afterwards, and we might move on to the next speaker. Thank you, Rory. So our next speaker is Dr. Sarah McLean. She's a consultant palliative medicine, and she just took a practice in Blackrock Clinic in 2019, but was working in Beaumont and St. Francis Hospice since 2016. Her special interests include the use of methadone for management of complex cancer-related pain, bereavement outcomes of family caregivers, and outcome measurements in palliative care. And she's going to give us a clinical update for general practice today. So thank you, Sarah.
Thanks, Aisling, and well done for holding out this far into the morning. So thanks for the introduction. And what I'm going to do is kind of in 2 parts, really just go through so much of palliative care is to do with service development and so on. So just a quick overview of kind of what's going on in the country at the moment, and then move on to some kind of very clinically relevant topics. Just a few of them, I'll just fly through them, just some little pearls. So I suppose to go back, you guys are all very familiar. I suppose, traditionally we would always been told, GPs, they see maybe 1 to 2 patients with palliative care needs a year. So, we really have to support GPs. But you guys are all seeing older patients with greater chronicity, with increasing palliative care needs now. So it's something that everybody is much more aware of. And when we think about palliative care, we think about Dame Cicely Saunders here, talking about, we're here to help you, not only die peacefully, but also to live until you die. The WHO and the HSE talk about improving the quality of life of our patients. And one definition, philosophy that I heard recently is this lady, Diane Meyer, she's a physician in Mount Sinai in New York, and she's really been responsible for the expansion of palliative care in the United States in just a huge way. And she talks about goal concordant care. So what is palliative care? It's really making sure that the treatment that we're giving to people matches what is important to them. So are we meeting their goals? And then underpinning all of this is, this philosophy of treating the person beyond the disease. So, when people, I get asked a couple of times a day by patients when I'm meeting them for the first time, like, what is palliative care? Why have I been asked to see you? What are you going to do? And it's really important. There's no hidden message. I don't know something that your oncologist isn't telling you. And I kind of tend to describe it in 3 different ways. So, we're here to, while your oncologist or your heart failure specialist are managing your condition, they're doing all the treatments and the investigations and the chemotherapy and so on, we're here to make sure that you have the best quality of life as possible, so to manage your physical symptoms. We're also here to support not only you, but also the people that are important to you, so your family, your caregivers, your children, and to support you in not only a physical way, but also kind of from a psychosocial, spiritual point of view. And then the third thing we do is just think a little bit about the future. So help you figure out what's important to you, what the goals of your care are, and how we can make sure that your care looks the way you want it to look, and make sure that we're planning ahead for you. So that sort of is a reassuring way to describe it to your patients, who I'm sure sometimes if you're referring them, they sort of might look at you a little bit strangely or want to know more about what exactly you're referring them to. So I suppose palliative care then and now, just to expand on that a little bit, I suppose in the olden days, sort of disease-modifying care and then palliative care and then sort of more integrated care, and now we talk about, specialist palliative care extending even into bereavement care, and then obviously they have the end-of-life phase there. So just emphasising that point. And really the key words in palliative care provision at the moment are early and integrated. So, referring people at diagnosis of a serious illness, a life-limiting illness, and integrating palliative care into their disease-modifying care. So this is a study. These are 2. Suzanne Ryan is a fellow, an Irish fellow in Toronto, and Breffney Hannon is an expat Irish trained girl working in Toronto. And they've done a lot of work looking at models of early integrated palliative care. So what patients like about it is all these things: good symptom management, holistic care, help with decision making, and preparation for the future. So that's all really nice, but does it actually help improve outcomes? So this is a slide describing the TAMEL study, which is from 2010 now. It's almost 10 years old, which is amazing to think. When this study was presented at ASCO in 2010, there was huge excitement about it. So, if a chemotherapy or if a drug had been presented at ASCO with the kind of survival benefit that this trial presented, it would have made headline news, all over the world. And it did, it got a lot of attention. So this was a randomized control trial of early palliative care and versus standard treatment for patients with newly diagnosed stage 4 non-small cell lung cancer, done in Harvard. And what they showed was that early palliative care led to improved quality of life, reduced symptoms such as depression and anxiety, better outcomes in terms of family caregivers and family satisfaction with care, and reduced aggressiveness of care. So these quality indicators, like giving chemotherapy less than 14 days before death, they all improved. And then this improved survival. Now, so this has been replicated in various studies, never quite to the same extent, and I suppose there's still a lot of debate over exactly what the best model of palliative care is, but this was really a game changer in terms of palliative care provision in terms of arguing for it and making a case for it. So, as if that wasn't enough, I suppose we all know about the ageing population. And it's something that you are certainly seeing in your GP practices. So increasing age of ageing population, increasing chronicity of diseases, and this is just an example of this sort of changing demographic pyramid. So the pyramid to the kite is what we're going to be seeing, or the less kind people call it the pyramid to the coffin shape population pyramid. So, you know, we're going to have more burden on our healthcare system and social care system, and we know that people are really unrealistic when they think about the amount of care that they're going to need into the future. They just, you know, if you know, why would they? They don't, you know, people just don't. I suppose it's that cognitive dissonance, isn't it? But we, you know, we need to think about how we're going to provide all that care for our population. And Ireland is certainly not immune to this. So we have one of the fastest ageing populations in Europe. I mean, in the States, 10,000 people turn 65 every day. So I don't know what the number is in Ireland, but you know, we're very rapidly aging as well. And Pauline Kane, who's a colleague she works in the Midlands now, but she did a PhD over in King's, and while she was doing that, she did this study of death cert data basically in Ireland. It was published in the Journal of Pain and Symptom Management in 2015, and she really described that from death certs data, 80% of deaths in Ireland are from conditions which benefit from palliative care, which have palliative care needs, either in terms of physical symptoms or complex care management. And this is higher than you see in the UK and Australia. And importantly, I suppose it isn't from the heart failure, from cardiovascular conditions, it's really from things like dementia, neurodegenerative diseases, as well as cancer. So that's just a bit of context in Ireland. Yeah. So can specialist palliative care, can we provide all of this care? Probably not. So there needs to be, you know, a changing model of care, and you know, thinking about the better models of care, which is where early and integrated comes in. But you know, refer to specialist palliative care for complex patients, regardless of diagnosis. Intermittent and not continuous support, so you'll be seeing more of this sort of dynamic model of care. So you might be referring people to specialist palliative care, to community palliative care, and then, you know, a few months later you might get a note saying, well, this patient is either discharged or on hold, but refer again. That's not saying that, you know, they're cured or anything, but it's just saying at the moment, actually, they don't need us, but, you know, we're here if you need us, and feel free to get in touch. It's no longer the sort of refer to the hospice and they'll follow them forever, so you will be, please do. So the 2011 report really showed that these were the main challenges that GPs were facing in providing palliative care. Paul Gregan, who I'm sure a lot of you know from Blackrock Hospice and down in Dean's Grange, chaired this report or was involved in it. And then the 3-year development framework back in 2017 really showed that there's still a lot of work to be done in terms of supporting primary palliative care, especially in terms of getting out-of-hours advice from the hospices, out-of-hours handover, and so on. So there's working groups and so on working on those elements of care. And then the HSE model of care has been done by the clinical programme, which is a HSE or CPI collaboration, and really it sort of aims to tie all of these elements of care together. So this is all available on the HSE Palliative Care Programme website, but if you need to know anything about palliative care in Ireland, it's on the model of care. That's the idea anyway. So with that, then I'll just move on to some of the clinical updates. I know we're a little bit pushed for time, so I won't kind of labour on too much. So I'm just going to cover a few important topics that that I and you see. And that can be challenging. So the first one is this whole role of immunotherapies. I'm not an oncologist, but so this is challenging for palliative care physicians as well as GPs, I'm sure. So, you know, we're all aware of immunotherapies, the controversy over ipilimumab and the funding of it. And, you know, these are, I always kind of feel bad when I'm not fully up to date, or when I see a drug that I've never heard of on a letter, or one of my patients is on it, and but then you know, I was talking to one of the ANPs there that I work with recently, one of the oncology ANPs, and she was like, you know, we can't keep up either. So that's kind of where we're at. So it's really important to be aware of these therapies, but, you know, not to feel bad when we don't know the ins and outs of all of them, and I see them a lot more frequently than you guys do probably. So I'm just going to fly through. This was a nice piece done last year by a girl I worked with in New York, Alison Wiesenthal, who's a palliative care attending. She was a fellow and then an attending over in Memorial. And this is the top 10 tips for palliative care clinicians caring for patients receiving immunotherapies. So it's a bit, the slides are boring, but the points are kind of useful, hopefully. So, you know, most immunotherapies are checkpoint inhibitors, so like Pembro, Ipi, the ones that you hear about. Obviously, there's loads and loads of other novel therapies, but these are just the ones that can be tricky for us clinically. One of the big issues with these immunotherapies is the unique side effect profile. And we're all used to traditional chemotherapies, you know, nausea and vomiting, febrile neutropenia, you know, those are sort of the things we're used to with our patients who have cancer. But these drugs just open up a whole new world of side effects. So some of the most common ones are the dermatologic side effects. So you have patients with weird rashes, weird itches. They can get GI side effects. They can get transaminitis. And then the really challenging ones are the endocrinopathies. So thyroid dysfunction, hypopituitarism, loads of them. And then obviously the one to be really aware of is adrenal insufficiency. So there's this whole myth as well about the role of steroids. Especially in some of the, I suppose, the more kind of complex immunotherapy, so CAR T-cell therapy, which we don't have in Ireland as of yet, you know, there's a real no-no about steroids because it's thought to reduce the effectiveness. But I suppose we know that steroids don't reduce the efficacy of checkpoint inhibitors, and they're sometimes necessary and life-saving for the side effects and will allow people to continue on these therapies. Oncologists will always be doing baseline labs before treatment. So if you have somebody and if you're checking bloods and you have no reference, then they should have a set in their hospital where they're getting their oncology care. The big thing with these drugs is that the immune-related side effects and the symptoms related to cancer can resemble each other, and it can be really, really difficult to figure out what's a side effect and what's progression of disease. I'll just go through some more of these side effects and then we'll talk about, I'll just mention that in a bit more detail. You know, we all know about the exceptional responses that do occur in a subset of patients, but we have no idea in most cases who is actually going to benefit from these exceptional responses. You know, there are clues in the immunohistochemistry and so on, but it's still unpredictable. I'm recently kind of back to work after a period off, and the Monday I started at about 5:30 I got a phone call from one of the oncologists saying, "Sarah, can you come and see this patient? She's in a really bad way. She's got fulminant liver failure. You know, she's a mess. I'm going on holidays for 2 weeks." And so I went up. She was a mess. I mean, I thought she was going to die. And in the next couple of days, she had absolutely awful liver failure. She was nauseated. She was fed up. She wanted it all to stop. And she was on dabrafenib and couldn't tolerate it because she was so nauseated. So we put her on a driver with some Zofran. She had a previous allergic reaction to steroids, but I still kind of thought it was worth giving her some steroids. We used methylpred because she'd had a reaction to dexamethasone previously, and she was fine with it. She resurrected, like she is now at home, probably on holidays somewhere. Incredible response, and the oncologist came back from holidays and was like, "Oh, very sad about her," and he was so shocked. So again, don't feel bad when we don't know everything, because the experts are still not able to predict. Endocrine adverse effects can be serious and should always be considered in your differential diagnosis if you see a patient on one of these therapies who's unwell. Patients who are used to chemotherapies can be very scan focused, so it's important to say these aren't your normal pattern of scans after 3 cycles or 6 cycles isn't necessarily going to be what your oncologist is going to be doing. And then there is this phenomenon of pseudoprogression, which I don't think is that common, but it's something to be aware of. And then there's new classes of therapies coming down the line all the time, so they're all going to have their own side effect profile. And then I suppose one of the big challenges is this prognostic uncertainty again, experienced by patients and oncologists. And so I think in palliative care, our role is really about supporting patients and our colleagues through this, and using really, really good communication to help people deal with it. And that old thing of hoping for the best but planning for the worst is still rings as true as ever. And just I'll go back to this thing about the adverse effects and symptoms related to cancer. They really can resemble each other very, very closely, and yes, there are some clues in, so for example, a rash might happen before a very severe bout of colitis, but it can be really, really tricky to figure out what's what. And I suppose I, have had a number of times, the community palliative care nurses, in my previous job I worked over in St. Francis Hospice in Raheny with the community palliative care team, and nurses coming back to the hospice and saying, gosh, so-and-so, they've really plummeted, they're really unwell, I think they're beginning to die. And having to say, well, actually, do you know what? Let's pull back, look at the bigger picture, and maybe it is referring people into hospital where you previously would not have. Maybe it's doing bloods where you previously wouldn't have been as interventional, but it really is just making sure that we're not missing these side effects, and giving patients the care that they need. I think as we all get more used to these treatments, that's happening less and less, but it's still something that does occur, and just really important if someone is on one of these treatments, just to bear it in mind. So, okay, the other thing I just wanted to talk about briefly was obviously the pharmacological management of cancer pain is a huge part of palliative care practice. You may all be aware of these national cancer pain guidelines. They were published in about 2015, I think, maybe 2016. I worked on them. They're really useful. What they have is, this is just a poster summary that is available, and this is an example of just an opioid conversion chart. So these are all available on the HSE website, and there is summary documents. Missy, our palliative care CNS, has some of them outside, but they're there to be, for you to print it out. They're a really useful resource. There's patient information leaflets on pain, debunking myths around opiates, and there's audit tools, there's loads of different resources. So I would encourage you to make use of those. Obviously, you could spend days and days on opiates in cancer pain, so I won't even attempt to go through the detail, but just to make you aware that those are available if you're not already. There's one issue that I will just focus on a little bit, because it is sort of an emerging evidence, I suppose, emerging finding. So this is the whole issue of the WHO analgesic ladder, which, as we know, has 3 steps. This whole increasing evidence backing the use of a 2-step rather than a 3-step ladder. So, the ladder is non-opiates, weak opioids, strong opioids. So what we know, and this is like an old study from the 90s, that patients who go through the ladder, so they go from a non-opiate to a weak opiate, they generally need a switch within a week to a step 3 opiate if they have moderate to severe cancer-related pain. Mary Fallon in Edinburgh has led a lot of the work on this, and she showed a few years ago that patients are 5 times more likely to have poor pain control if they're on step 2 as compared to step 3. And that led to another RCT randomizing patients to a 2-step versus a 3-step ladder. So by a 2-step ladder, I mean patients going directly from a non-opioid analgesic to a strong opioid. So skipping your tramadol, your Solpadol, and going straight to Oromorph for oxynorm. And by the way, the evidence does show that even though Oromorph is still considered sort of probably the drug of choice to start if you're starting a strong opioid, there's really no evidence for one strong opioid over another. So if there's reasons to start with morphine sulfate, oxynorm, hydromorphone, even methadone in the specialist setting, or fentanyl, they're equally valid choices, just depends on the patient profile. But anyway, going back to the 2-step versus the 3-step ladder, so what Mary Fallon has showed is that by going directly to a strong opiate, you achieve pain control more quickly. And so 7 days versus 11 days, which might seem like a small difference, but if you are in severe cancer pain, then it isn't really, with no evidence of increased toxicity. And I think, clinical experience would show really that probably less toxicity, because the weak opiates really are quite dirty drugs. They do tend to cause side effects. So in my experience, and I think most people working in specialist palliative care have been adopting this approach anyway. Really the role for weak opiates has almost disappeared when you're managing moderate to severe cancer-related pain. So I'm not talking about non-malignant pain, this is just cancer-related pain. So that is a bit of a change. Just a word on constipation, because it wouldn't be a talk on palliative care if we didn't mention constipation. Again, these guidelines were published, they're really useful, they're shorter than the pain ones. So, we know in the general setting, palliative care setting, there really isn't evidence for one laxative over another. A combination of a softener and stimulant is still what we should be aiming for. Everyone prescribes lactulose, but it often isn't tolerated. So for opioid-induced constipation, I suppose the guidance is slightly different in that the guidance is to optimize monotherapy with a stimulant first. So what we would use is Senna first line. And people often prescribe Senna just Nocte. It can actually be used 2 TDS with really good effect. And then add in your softener or Movicol after that. And then increasing role for opioid receptor antagonists. So Targin, the OxyContin, methylnaltrexone, naloxegol, and then Relistor, methylnaltrexone are all options for opioid-induced constipation. Because it's really common, especially in the palliative care population, and it's something that is really underdiagnosed and under-recognised, especially in our patients in the community. I think people think of it when people are in hospital, but they don't really think of it when people are at home. And then this, delirium can be hypo-alert as well as hyper-alert, so as well as a mixed pattern. So this trial, just to mention it, kind of threw the cat majorly among the pigeons a couple of years ago. David Currow is one of our colleagues in Australia. And this was a double-blind RCT in mild to moderate delirium. No patients had severe delirium. And it really questioned the benefit of using antipsychotics for delirium. So there was a lot of debate over, are we doing the right thing by giving a little bit of haloperidol to these patients? And really, I think the more people have kind of looked in, kind of analysed the study, it really was quite flawed. So practice initially, maybe there was a bit of a wobble, but now we're really sort of back to, yes, the benefits of antipsychotics in a delirium outweigh any risks or question that they're not more effective than placebo. So you may not have come across this study, but it's a useful one just to know about. Thanks, Ashley. I'm just going to skip that. And just a quick word on outcome measurement in palliative care. So this is important because when you're talking to specialist colleagues in the hospitals or community palliative care teams, you might hear this language being used a little bit more, and that's because there's a huge push, both nationally and internationally, to look at how we are measuring our outcomes in palliative care, and that's really because it's more difficult in palliative care. So if you have someone who goes in for a hip replacement, you can tell pretty much, quite easily if they've done well or not. In palliative care, because our population they're obviously getting less well as time goes on, they're very heterogeneous. It can be more difficult to say, well, yes, we're doing a good job or we're not doing a good job. And we know in healthcare, David Currow, who did the delirium study that I mentioned, he has this thing saying, well, actually, do you know what? A drawer full of thank you letters, is that really enough these days to say that, yeah, you're doing a good job? It's not really. So we need to look at how we measure outcomes in other ways. So what the main kind of term that you might hear mentioned is this term phase of illness. So this is an Australian concept that we use in palliative care to describe the stages of advanced illness according to the care needs of the patient, the family, and the suitability of their care plan. It's useful because it predicts resource use, and it's used as part of a suite of tools to measure palliative care outcomes. So you might hear the nurses talking about a stable patient, an unstable patient, a patient in the deteriorating phase, a patient in the terminal phase, and then bereavement. So the group of patients that we're really interested in are these unstable patients. So that doesn't mean that they're like hemodynamically unstable. It just means that we really need to think about what we're doing because they have a new symptom, or their existing symptoms have escalated, or maybe their functional status has changed very rapidly, and we need to think about how much care they need. And so on. And what we're really looking at in terms of quality of care is for somebody not to stay in the unstable phase for longer than 3 days. So that is sort of a really important quality measure in palliative care. And these measures can be used at home, in the community, in inpatient hospital and inpatient hospice settings. PCOC is the Australian Palliative Care Outcomes Collaboration. I'm not going to go through all these figures, but just to say that I suppose it's a national project. 88% of palliative care services engage with it, and it has really been shown to improve outcomes. So most importantly, I suppose not even just at the service level, but really in that sort of that key measure of quality, equity. So it really shows that it's really led to a reduction in variation across all the different services in Australia. And then just a little bit how it's being used in Ireland. So it is being used. It's being used in Dublin, in Harold's Cross, in Milford, in Limerick, and Marymount Hospice in Cork. They're kind of really pushing it. But how it's being, so these are just some examples of how it's being used in services. So, for example, on the north side, there was 2 community palliative care teams, Raheny and Blanchardstown. We used these phases data to show that the patients in Raheny were frailer than the patients in Blanchardstown. So actually, we said, well, do you know what? We need more occupational therapy provision to Raheny. So it can be used really to push service provision. And then, just some, used to compare pediatric patients to adult patients and patients in nursing homes compared to their own homes. So really useful at a practical level. Okay, I'll stop there. And just to remind everybody that it's Palliative Care Week this week.
So I suppose I just want to ask a quick question. You mentioned, about choosing the right opiate and that there's not one. Is there, if you look at antiemetics, is it the same kind of thing, or is there one that you prefer for patients with nausea?
So with antiemetics, what we talk about is having a mechanistic approach. So thinking about what the underlying cause of the nausea is, and then choosing an appropriate antiemetic. So for opiate-induced nausea, which can occur in the first kind of 24, 48 hours, but is one of those side effects that people get tolerant of. So constipation, people do not develop tolerance to constipation, opioid-induced constipation. They need to stay on a laxative throughout treatment. Nausea, they do get accustomed to. So, and the opiate that we most commonly, or the antiemetic, that we'd most commonly use would be metoclopramide for that. And then, so for nausea related to, for example, biochemical changes, cyclizine would be the antiemetic of choice, just because of the different receptors that are involved in those pathways.
Okay, super. Are there any questions?
Oh, yeah, sure.
Sorry, could you repeat the question, please, for the online?
Just to show the slide about deprescribing, you skipped over.
I did, yeah, in the interest of time. Can I go back onto the slides? Thanks. Yeah. So there's two sides. So this is actually like a thing that I did when I was an SPR up in Drogheda back in like 2010, just showing that the medication burden for patients towards the end of life, we're really bad at decreasing the medication burden, it increases. So we tend to keep people on their regular medications, so their statins, their aspirin, their antihypertensives, and then we add in all these other medications for pain and for nausea and other symptoms. As part of this work, actually, my colleague Barbara Sheehy-Skeffington, who's working over in London at the moment, she did focus groups and some qualitative research on the impact that medication burden has on the families of patients towards the end of their lives, and it's enormous. So I suppose I just wanted to highlight, then this is a more recent study in palliative medicine. Just wanted to highlight the importance of thinking about polypharmacy. There are criteria, obviously you'll all be aware of like Beers criteria and stop-start guidelines and so on, but as yet we don't have any guidelines specific for patients in the palliative care setting, and I'm working with a postdoc over in the College of Surgeons, a pharmacologist who is doing some research with a PhD student in developing those guidelines, so hopefully that'll kind of bring some clarity to it.
Sorry, a real-life case. I had a lady with lung cancer, and she was on oral medication, and she was at home, and she was doing well. Over the weekend, then she deteriorated, but she was still able to take her oral medication. And get a phone call 9 o'clock on a Monday morning, and the surgery full. And now she is nauseated, she can't take them orally, she's in severe pain. I, at that moment in time, wasn't able to run out to the house and give her something I decided, and I couldn't, the palliative care, obviously she needed a syringe driver. Palliative care weren't available for another 4 or 5 hours. Was I right or wrong in giving her a fentanyl patch in the interim? Or how do you tie that together?
Gosh, it's an interesting question. I suppose there's two questions, I suppose. Why was she nauseated and how to manage the pain?
Yeah.
I suppose fentanyl patches aren't great for acute pain because they take a little while to kind of reach steady state.
Yeah.
So we tend to use something like maybe Oromorph or Oxynorm liquid or something like that. But obviously if she isn't able to manage orals, then that's tricky. Yeah. And what did you do with her, apart from giving her the fentanyl patch?
I gave her the fentanyl patch. As it happened, I gave a prescription to the relatives. Mm-hmm. Then they were met by palliative care who said, I can't go out for 2 or 3 hours. I happen to be the chemist. In this case scenario, I just can't make it out to your house. Mm-hmm. Don't take the fentanyl patch. The lady's in severe pain. It was one of those dilemmas. I said, I must find out for again, is there anything one can do in the interim?
It's really hard not knowing the case, I guess.
I know.
There's so many other factors.
Yes.
Yeah.
What about the FT lollipop?
Oh gosh, yeah. Yeah.
Yep.
I suppose if you're in a real pinch, maybe, and if they were very, if the priority was to keep the patient at home, and could the public health nurse have gone out and given her an injection of something, or no. Yeah.
Dr. Carla, thanks for the talk, and I have a question here. And when we talk about palliative care, we're talking about the final stage of a critical disease with ongoing symptoms and rapidly deteriorating the conditions of the patient. Is there any specific point in the flow chart when we consider or should consider to talk to the family and having some family support, because these patients may require a lot of support on the families?
Yeah, so palliative care, I suppose, not the final hours to days of life, from diagnosis of a serious life-limiting condition, early and integrated improves outcomes. Family support is part of palliative care. If you're providing palliative care as a specialist, or if you're a GP using a palliative care approach, support and communication and information provision for families is part of what you should be doing. I don't know, does that answer your question?
I was thinking about a specific point in the flow chart when we should involve the family in the diagnose, the approach, and the management of those deteriorating symptoms on the patient.
I mean, I think, sometimes, there is no specific point at which you should involve the family in somebody's care. I suppose it should be an integral part of using a palliative care approach, is that holistic sort of model, Sometimes what happens is that, what we call transition points. So if somebody is admitted to, so say you're a patient with chronic COPD and recurrent exacerbations and, very frequent admissions to hospital, and one, there'll be one particularly bad admission, and so sometimes those transition points are a really good opportunity to kind of step back and reassess and kind of look at the goals. They would be good points at which to sort of have these hard conversations with families.
Thank you.
I wonder, are there any guidelines on managing palliative care patients on methadone?
Sorry, who am I?
Patients who are on long-term methadone.
Methadone for cancer pain?
No, they are on methadone for drug addiction, long-term, and are there particular guidelines on what we should do in that situation?
Yeah, so there's a section in the National Cancer Guideline pain guidelines on patients with a background of substance addiction and on methadone. The main thing to be aware of is, and these patients are really prone to cancer, so they have, patients on methadone maintenance have higher incidence of cancer than the general population. Head and neck cancer, Paul O'Neill would go to town on this. They really get sick, and then I suppose when HIV/AIDS was more of a problem, it was again kind of that whole sort of issue. But yeah, the thing to be aware of is that because of the neuroplasticity of being on chronic opiates, their pain is more complex and it can be more challenging to manage than people with no history of using opioids. So they'll often over-report, or what's termed kind of pseudo-addiction or pseudo-addiction, the sort of patients reporting pain and people feeling that they're over-reporting, but they actually do have genuine pain. So we just need to be mindful of that, that they're also, opiates are kind of less effective, so more of a role for using adjuvants, so like neuropathic agents.
And are there risks attached to cannabis use in situations like that?
Oh gosh, that's a whole other discussion.
I just have a patient at the moment who's a young girl, actually she's in her 40s, who is a palliative care patient at the moment. And actually, when your colleague was assessing her on a domiciliary visit, she telephoned me subsequently to tell me that she had 3 joints during the consultation. She's on her methadone, and she has cancer pain as a result of secondaries in her pelvis and in her lumbar spine, And so it's posing kind of big issues in the sense of, she's obviously terminal. I don't want to, kill her inappropriately, and at the same time she is particular about not producing dirty urines in order to get her methadone.
Yeah.
So that there's just dilemmas there.
So does she not want to be on opiates? Because that's something that you often see as well as patients who are well maintained.
That's right. Yeah, she's refusing opiates and she's had pain. We've given her some of the step 2 or other, and it wasn't that effective, And she's resisting patches,
They're really complex patients, aren't they?
And actually, yesterday she told me she wants to die at home. She doesn't want to go to the hospice.
Okay, and she's known to community palliative care, is she, or no?
Well, she's agreeable to community palliative care, but just at home, it's just it's the unreliability of not knowing what she is taking or what she may have taken, and that one could, one could probably tip her over the top, with giving her something.
Yeah, it's unlikely to tip her over into toxicity because her body is so used to opiates. But I suppose it's often those patients who are very resistant. It's actually persuading them to take appropriate analgesia. But in the meantime, I suppose just optimize their non-opioid analgesics. So like paracetamol, NSAIDs if appropriate, and adjuvant agents. Yeah. Okay. She may need admission to a specialist inpatient unit for pain if it's a real problem.
Yeah. Thanks very much.
Okay, my question is, let me set up a scenario so you can understand better my question. Sometimes patients have been referred to the palliative care team, and patient is not aware of that. So in a community setting as a GP, even family members, they approach to us and they say, well, patient should not, he shouldn't know that he has been, or she has been diagnosed with a terminal cancer or whatever, and has been under palliative care. So what we should do at that point, should we let patient know or not? That my question is, because I have come across a couple of times in conditions like these, so believe me, I don't know what to do. So it's very complicated.
It can be complicated. I think it comes back to that whole issue of kind of stigma around using the word palliative care, and I suppose it's about educating people. So yeah, I think it would warrant a sit down and explanation and education and reassurance for sure. Yeah.
Okay, thank you very much, Sarah.
Thanks.
We're just going to do a quick raffle, and then I think there's refreshments outside if anyone wants anything. Carolina for Salzburg. Chris Healy.